Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent sponsorship from Johnson & Johnson.
This program is presented by Medscape Education Global.
Hello, my name is Philippe Moreau. I'm working at the University Hospital of Nantes in France, and welcome to this program titled Personalized Pathways, Tailoring Care for Patients with Newly Diagnosed Multiple Myeloma. I'm pleased to be joined today by Dr. Paula Rodriguez Otero. She's working in the hematology department in Pamplona, University of Navarra in Spain, by Professor Evangelos Terpos, who is working at the hematology department at the University Hospital of Athens in Greece, and by Roman Hajek, who is working at the Department of Hemato-Oncology at the University Hospital of Ostrava, Czech Republic. And I would also like to introduce Barbara Leonardi, a patient advocate with Myeloma Patients Europe, who will bring the important patient perspective to the discussion. And with that, let's listen to a word from Barbara, who will discuss the burden of newly diagnosed multiple myeloma and the importance of person-centered care and shared decision-making.
Hello, my name is Barbara Leonardi. I am the president of Myeloma Patients Europe and a patient advocate. I have been living with multiple myeloma since 2019. Myeloma is quite an unknown disease, and many patients hear about it for the first time during their diagnosis. What comes as a huge shock is the incurable nature of the disease and the lifelong treatment. Often there is not enough time during an appointment to discuss the complexity of the illness and the complexity of the treatment. Patients leave the appointment overwhelmed and with many questions. They seek answers, they want to find information, which is not always easy, because it's not always easy to find information that is delivered in plain language and in their national language. What's more, navigating through the health system can also be challenging, especially for those who don't have any experience of serious illness. So it's difficult to understand who is responsible for which part, which aspect of care, and what the patient's rights are. Why is it important to have personalized care in multiple myeloma? Because multiple myeloma is a lifelong disease and requires a long-term treatment, patients cannot put their life on hold for the duration of therapy. They need to learn to live with myeloma. Moreover, patients join this marathon at different stages of their life and have different needs and different expectations. That's why it's so important to have person-centered care, because the needs and the expectations need to be taken into consideration when planning the treatment. Person-centered care improves trust and quality of life, because the whole context of patient life is taken into consideration. Shared decision-making is often misunderstood, and I need to highlight that it's not about patients demanding a specific treatment or particular therapy. It is about a dialogue and mutual understanding. Shared decision-making combines clinical expertise with the patient's context of life. Now let me talk briefly about the role of patient advocacy and patient organizations. Patient advocacy groups play a vital role in supporting those affected by myeloma and those treating myeloma. We are a bridge between clinical care and daily life. Patient organization groups support patients by providing reliable information delivered in plain language. We offer peer support, which is essential for mental health and well-being, and we help navigating through the health system and understanding the patient rights. But that's not all, because we also support the clinicians. We reduce the time burden by educating patients about the disease, about the treatment options, about the side effects, and about the health system. And on the other hand, we also bring in the patient perspective. We allow the clinicians to understand what it is like to be on the other side, and we share the insights that patients may be too shy to share during an appointment in the clinic. With that, I'd like to return to Dr. Moreau and the panel to continue the session with their case-based discussion. Thank you.
Thank you, Barbara, for your insights. That's true that it is so important that we keep the patient perspective in mind. Now, shifting to the recent guidelines, Evangelos, if you could summarize, in fact, for us, the frontline treatment of patients eligible or not for autologous stem cell transplantation that will be published very soon in the coming days. These are the EHA-EMN European 2025 guidelines, and you are one of the lead author of this paper. So please tell us what are these guidelines currently.
Thank you, Philippe. These guidelines present what's going to happen during the next couple of years, I believe, because I don't think that we can have more detailed guidelines for more than 2 years for patients who are eligible and not eligible for transplant, both newly diagnosed and relapsed refractory multiple myeloma, and also for the complication of the disease. So regarding patients who are newly diagnosed, we have again the division between patients who are eligible for transplant and non-eligible for transplant. Transplant remains treatment for these patients, despite we all know the MIDAS trial that was published after the acceptance of this paper, so it's not discussed. So for those patients who are eligible for transplant, the new data is the entrance of daratumumab with bortezomib, lenalidomide, and dexamethasone as induction, or isatuximab, bortezomib, lenalidomide, and dexamethasone. 4 to 6 cycles of induction followed by high-dose melphalan and autologous transplantation. We also suggest 2 cycles of consolidation if the patient received 4 cycles of induction with the same induction regimen, and then maintenance with not only lenalidomide but also with daratumumab plus lenalidomide based on the Perseus study. In these guidelines, also a double autologous transplantation is recommended with lower level of evidence than 1A, which is the level of evidence of all the other treatments that I described, with 2B for those patients who have high-risk cytogenetics, although, as you know, the MIDAS trial has put this in big question. For those patients who are not eligible for transplant, the 2 new entrances are the quadruplets of daratumumab or isatuximab with bortezomib, lenalidomide, and dexamethasone for patients who are rather fit or up to the age of 80. For patients who are frail, we suggest, based on the IFM study, the combination of daratumumab with lenalidomide with possible 2 courses or 2 cycles of dexamethasone during the 2 first cycles. So this is more or less what is included in the guidelines for the newly diagnosed patients.
Thank you, Evangelos. That's very clear, in fact, and we are now moving more and more for quadruplet combinations up front, and that's what we are going to discuss. And to further explore treatment selection in newly diagnosed patients, let's talk through some scenarios. The first case is a 62-year-old fit patient with a standard risk disease and no comorbidities. So, Paula, what will be your treatment of choice for this patient? What are you going to propose indeed? And are you going to follow, in fact, the future guidelines?
Yeah, thank you, Philippe. I'm very happy to be part of this discussion. So I think this is the ideal patient. So young, without comorbidities, fit, and standard. So this is the patient that I will follow the new proposal with a quadruplet. So daratumumab VRD based on Perseus data. So typically I will do 4 cycles of induction followed by transplant, 2 cycles of consolidation with the same scheme, so DVRD, and then in the ideal world, and waiting for reimbursement in Spain, So I will also like to have the double maintenance that is proposed also in this study with daratumumab in combination with lenalidomide, 2 years, and then with the possibility for those patients that achieved and sustained MRD negativity and CR, for 1 year with the possibility to stop in daratumumab and continuing just on len alone. So that will be my ideal choice, and that is what I will do in Spain today.
And Evangelos, how are you going to use MRD outside clinical trials? Are you going to use MRD systematically for all patients to guide the duration of maintenance? Because into the Perseus study, some patients could stop daratumumab maintenance after 2 years when they were in sustained MRD negativity. Is it something that you are going to do systematically now that we have the results of this very important study that is directly implemented into the guidelines?
Yeah, I think this is a great question, and we have implemented the MRD measurement using next generation flow. But with that in our hands, the detection limit is 0.2 to 10 to the minus 5. So it's not so easy, at least to our hands, to go to 10 to the minus 6 with the Euroflow. So probably if we want to go at a lower level, like 10 to the minus 6, we need to have next generation sequencing probably. And based on that, we may have some treatment decisions. The one is coming from the Perseus study, because this is a randomized study, a big study that will give us some very good results of stopping daratumumab or not, if this is a good practice in those patients who achieve at least 12 months of sustained MRD negativity. However, in our practice, and we have published a small phase 2 study in blood a few months before, we've seen that a patient who has achieved 3 years sustained MRD negativity, but this patient had received mainly triplets with VRD or VCD followed by transplant and then len maintenance. If they managed to do that, and in our hands this happened in approximately 1/4 of the patients, then if we stop lenalidomide, almost another 1/4 of the patient in a median follow-up of 3 years become from MRD negative to MRD positive. And then 4 patients, which is 7% of the total, had biochemical progression. But always the pattern was from MRD negative to MRD positive and then to biochemical relapse if you are doing the test every 6 months. The vast majority of these patients had high-risk cytogenetics. So I think that we need more data before we suggest the stopping of maintenance, at least one drug that Perseus will tell us, or both drugs that I don't know that will have good results from any study for that.
Thank you, Evangelos. Very clear. And Roman, I believe that in your country as well, you will select transplant systematically for 62-year-old fit patients. And what about the duration of maintenance? Because we learn from Perseus that more than 2/3 of the patients were in sustained MRD negativity during 2 years from the start of maintenance with Dara-Len. So are you going to prolong the duration of lenalidomide until progression, or are you in favor of fixed duration of treatment? And Evangelos said that we don't have quite a lot of data currently, but what will be your choice, in fact?
Oh, I definitely prefer fixed duration treatment. To create some treatment-free window, I think it's very important for our patients. Agree with Evangelos that we still have not enough data, but even in real life now, in lenalidomide era, as in maintenance, after 3 years, if patients is sustained MRD negativity, the open discussion if continue or not. Of course, it's debate, and if patients agree to stop, we are doing it.
Okay, that's very important, and I believe that probably we had the same discussion following Perseus results in France. Probably we will select a fixed duration if possible, especially for those patients with a sustained MRD negativity 2 years. We've heard at ASCO that the PFS is really fantastic. 2 years sustained MRD negativity, the PFS is 98% at 4 years. So that's really fantastic results, and agree with you. Probably to have some treatment-free interval could be of interest for those patients. And Paola, Evangelos mentioned two quadruplet combinations prior to high-dose therapy. He mentioned VRD plus daratumumab and VRD plus isatuximab based on the results of the German HD7 study showing that with the quad ISA VRD, the MRD negativity rate is much higher compared with VRD alone. So any choice, Dara, isatuximab, do you believe that the two antibodies are quite similar in terms of efficacy, I mean?
Yeah, so yeah, I think this is a great question, and yeah, in my personal opinion, I believe that they are quite comparable. Of course, isatuximab, I mean, ISAVRD is still not approved or available, so we cannot use it yet. But of course, when it will be available, it will be either or. I would say it's true that ISAVRD in the HD7 study, I mean, the isatuximab that we have is still intravenous, but we have already the data from the randomized study comparing isatuximab IV versus isatuximab sub-Q in combination with POM, showing that, I mean, the efficacy is comparable, and of course it's much more convenient, indeed, with an on-body delivery system, which is a rather patient-friendly, I would say. So yes, in the future, both combinations would be available, and it will be difficult to choose because honestly I don't think we can make any difference in terms of efficacy or safety.
Thank you, Paula. And Roman, 62 fit patients transplant. But what is your age limit for a systematic autologous stem cell transplantation in fit patients? That's 65? And that was the age limit, let's say, in the past. And now we have more data up to the age of 70 years. So are you proposing systematically outside clinical studies up to the age of 70? We have Perseus, the German study, the cutoff limit was 70 indeed.
Okay, we had limit 65 8 years ago, and then we moved to 70. We keeping this limit even in our guidelines, Czech myeloma group, but now it's open, for debate because the outcome of quadruplets are so excellent, and even in our data from registry and in real world, we really can see strong benefit of transplant for patients which age between 65 up to 70.
Okay, that's an important information, Roman. But well, we will discuss this with some new cases because you know that Peter Sonneveld in a recent meeting showed the projected PFS of Perseus and the projected PFS of Cepheus. Cepheus, that's a quad without autologous stem cell transplantation, and there is a big difference. Median PFS
It
with
is.
Perseus could be 200 months, and median PFS with Cepheus could be only, let's say, and that's fantastic results already, 100 months. So let's move to the second case, in fact. And what if the patient was 67-year-old with a high-risk disease and no comorbidities? What could you propose, Evangelos, for this specific patient? High risk, 67, still quad for all if possible, but what about tandem? Can you rephrase about the tandem issue? Because that's proposed in the guidelines, but not sure that this is feasible and of benefit for the patients.
That's true. And definitely this patient, because he's fit, according to what we are doing, that we have moved the autologous transplant limit to the 70. So for 67, no comorbidities, high risk cytogenetics, we would go for a quadruplet-based induction followed by high-dose melphalan and transplant, and then again 2 cycles of consolidation, and definitely double maintenance. And if we talk about high risk according to the new high risk definition of IMS and IMWG paper, I think that the majority of these patients belong to the ultra high risk in the past. So for me, I would love to have an MRD negativity achieved in these patients, and definitely I will aim to do my best to achieve that, even if I need to have a PI also included in the maintenance. And at that point, I want to mention that in these guidelines, you don't see the quadruplets with carfilzomib to be included in the induction and the consolidation, even in the maintenance, not because these are not fantastic quadruplets, fantastic regimens, but because they don't have registrational, let's say, future. And this is what we have put in the methodology, that we discuss all these regimens in the text, but we have not included them in the recommendations or in the figures, because these carfilzomib quadruplets have not had a registrational, let's say, in the near future, registration approval. So to me, for example, for these high-risk patients, if I could, like the US physicians, they do it, I would substitute probably bortezomib with carfilzomib in the induction and consolidation. Although we don't have very, very stable, very clear data, although we have seen the Ischia, we have seen the Forte, we have seen now with Midas, that this quadruplet with carfilzomib probably may give better results and definitely higher MRD negativity rate. That to me, this is a must for the high-risk patient.
Yeah, Evangelos, you have raised some very important point. In fact, indeed, that's true that when we are looking at the results of the MIDAS study with KRD plus a CD38 antibody, the rates of MRD negativity, even in high-risk patients, is so high that we would like to use, and unfortunately, we don't have KRD plus a CD38 as a quad approved in Europe. That's probably feasible in some countries outside Europe, but unfortunately not for us. So, Paola, are you going to treat this patient high risk the same as a standard risk? I mean, quad, high dose, and 2 drugs as maintenance? Or would you prefer to use a tandem? Well, we have few data on the benefit of tandem, but some. So, what would you like to do, in fact?
Yeah, so first I would like to really, make the agree with what Evangelos just mentioned. So I think that in the new definition of high risk, that consider the majority of the patients to be what we called previously double hit myeloma. So the truly ultra high risk patient population. So these are the patients that is, if we look back, for example, to the Ischia study with isatuximab KRD, that also included a prolonged consolidation with isatuximab KRD for 1 year duration. If we look at the rates of MRD 10 to the minus 6, particularly in this population of ultra high risk, I think that they were the highest reported. So I think that these patients definitely will be better treated with a more potent eventually induction, but of course it will be difficult to get access in Europe because there is no phase 3 registrational study evaluating a KRD plus anti-CD38. So I will do the same as with the standard, so quadruplet induction, data, ISA, VRD. Now, tandem, great question. And you show, I mean, in the MIDAS study, particularly try to answer the true value of tandem. No, it's true that your definition of high risk were patients failing to reach MRD negativity, so were MRD positive patients after ISA, data KRD, I cannot remember whether it's that data or ISA, I think it was ISA KRD induction, 6 cycles. And then the patient got 1 transplant and then the second one. And in fact, there was no improvement in the MRD negativity rates with the second autologous stem cell transplant. So what we were doing in the real life already is we were checking for MRD. And if the patient either didn't improve the MRD rates after the first transplant or was already MRD negative after the first one, we really normally didn't perform the second autologous stem cell transplant. So like you, I mean, it's in line with what you showed with the MIDAS study. So in general, tandem only for patients that really improve the responses after the first one. If not, we will go directly to the consolidation. But definitely in the Perseus data, double hit myeloma continue to do poorly in terms to PFS. So probably this is the subgroup of patients in which Either we need to do more prolonged consolidations or eventually incorporate new drugs.
Thank you, Paula. Very clear. So, Roman, let's move now to another patient case. This patient is now 72-year-old, high risk disease, ECOG 1, with mild comorbidities. So, we understood that for all of us up to the age of 70 years, quad stem cell transplant, 2 drugs as maintenance is possible. But now the patient is 72, but high risk. So what will be your choice, in fact, outside clinical study?
Yeah, I have mentioned that in that specific case, we have strategy that patients is our partner. So we discuss two key opportunity: go to transplantation or not. And I think the currently quadruplets offer so good, outcome for such group of patients that I think it's a really appropriate treatment. On the other hand, we offer also transplantation in this group. This is mild comorbidity, so it's still manageable. So this is really decision is based on discussion with patients. Somebody want to transplantation, somebody want some triplets or quadruplets, because we currently use Dara RD, not quadruplets, but moving to quadruplets. So that's really based on the discussion with patient. It's not too clear, for
Yes, that's true that we need to discuss with the patients as always, with the risk, the benefit, the balance risk benefit. So Evangelos, for you, still a room for high dose and transplant above the age of 70 years from some patients or not at all? And if some, maybe high risk disease, because the role of high dose melphalan could be of importance, and this patient is 72. So, well, if,
In
well,
the majority
what is your point?
of our patients, we don't do a transplant at the age of 72, taking into consideration, of course, a lot of factors. Of course, if we talk for someone who was in the army before and is very fit and in the Marines, for example, I may think about that. But in general, we don't do it because in Greece, for someone who is above the age of 70, in order not to have any cardiac problem that will allow a transplant is only 8 to 10%, unfortunately, due to the heavy smokers and a lot of cardiovascular problems that our patients have. So even for the high risk, we are not doing a transplant if the patient is not very fit. In the case of very fit patients, we can discuss it in, as we say, patient-based. And we discuss with the patient, and we have done 2 or 3 transplants, as I remember, in such a group of patients. But the majority are now receiving a quadruplet with high-risk disease without a transplant.
Okay, they're very clear. And Paola, the same in Spain, same patient population, or 72 high risk, you would try?
Yeah, I don't think I have in my mind so clear as Evangelos the proportion of patients with comorbidities, but in general, 70 is our age limit. So above 70, it's in general no go for transplant. I remember 5 years ago, a 72 fit patient like this one, high risk disease, induction with quadruplet, and then go for transplant. And the transplant went well. But unfortunately, the 6 months after transplant, with the immune suppression related to transplant, it was very hard for the patient with severe and recurrent infections requiring several hospitalizations. So honestly, I don't feel very comfortable doing this, even in very fit patients at this stage. So in general, it's no transplant for above 70.
Okay, that's a good point. That's true that until very recently, we've heard about our German colleagues. They were proposing sometimes tandem high dose up to the age of 75. Maybe the German patients are more fit, let's say, able to tolerate. And I agree with the three of you. In France, for example, very few cases of transplant after 70 years, even in patients with high risk disease.
Honestly, I think it is very important to take the time with the patient and explain the different parts of the treatments. I always explain the patient that the first year of newly diagnosed myeloma treatment is an investment. It's an investment in future, let's say, health. Hopefully,
That's really, to my opinion, really critical, to explain as best as possible what are the goals of the treatments, what is also potentially the toxicity, and to highlight the burden of such treatment.
yeah,
Because during the first 2 to 3 years, the burden is so important, not only on the patient, but on the family as well. There are so many informations regarding the treatment, regarding the biology of the disease,
yeah.
how to follow the disease with the M spike, etc., to explain when to phone to the hospital, when they have to call the GP, for example, instead of the hematologist. And so we have to repeat and repeat again.
Yeah,
And
definitely. This is the key.
that's, yeah,
Yeah.
that's really key.
I always encourage patients to have questions, to be involved in this treatment decision, because, as I mentioned before, patients is for us a partner, in treatment decision.
Sometimes, Paola, we have few, but some very young patients, less than 40 years. And these patients could be very active, with kids and so on. And they say, okay, I don't want to have a treatment that is too strong, let's say, or time consuming, etc. So how are you trying to inform them? That's a very difficult situation.
Yeah, indeed. I mean, these are patients that they are not prepared, to have this disease in the, let's say, when they are living their best time of life and they have everything in front of them, no? But honestly, I think that these are the patients in which to get the best possible therapy is so important, because what you really need and what you really want is to prolong the lifespan of those patients that are so young as much as possible. I think it's all about communication with the patient, to share what you know, and to make them understand that although it will be impacting completely their life, it's important for them to get the best possible treatment, to get into the best and the deepest possible response, to have the longer progression free survival. So there are always ways, if you want to. I mean, if it's a young woman that has not had yet kids and want to have kids in the future, so you can eventually, preserve the ovary, making sure that there is no myeloma cells in there. So there are things that you can do to try to put all together, so the treatment of myeloma and the life of the patient. So I think it's our job to be there with them in the journey and helping them to move forward.
Thank you, Paola. And Evangelos, was one question for you. What is to your opinion, the importance of biological age versus chronological age in tailoring treatment?
This is important because we may have someone that, according to the age, is eligible for transplant, for example, but has frailty or cardiovascular diseases. We do have some patients, even at the age of 55 or 60, that they've had a myocardial fraction in the past, and some severe comorbidities that the autologous transplant cannot be given in these patients. On the contrary, we have some patients like the one that we discussed, 72-year of age, with high-risk disease, but very fit. And in these patients, we may think of a transplant. So I think that it is important to evaluate not only the chronological age, but also the biological age of the patient. And this has been shown in several studies. The comorbidities is the most important part of the frailty of the patient, and definitely if the age is above 80. Otherwise, we can see all the variations among the patients.
And now, Roman, another case for you, 77 years old, standard risk, diabetes, and intermediate fit. What will be your choice? We have now plenty of data from 70 to 80 years with Cepheus, IMROSE, Benefit, showing that quad can be proposed with very good results in terms of response, MRD negativity, and most importantly, PFS. So for this patient, what is your choice?
Okay, I think it's typical patients, and clearly the comorbidities affect treatment selection. So it's seen here the diabetes. So it's clearly we will try to reduce dexamethasone or even avoid dexamethasone. So that's the first step. So then the discussion now is when to use triplets or quadruplets. We're still learning. It's still learning curve for us with quadruplets, but there are so strong synergistic effect between dara, lenalidomide, and lenalidomide bortezomib. So our recent strategy trying to offer these combinations to most patients, even in these conditions as these patients, reducing doses, but add to daratumumab, lenalidomide, and bortezomib if possible. So my suggestion for these patients would be probably triplet without dexamethasone or with really just 1-2 months of dexamethasone if tolerated.
Okay. Evangelos, do you agree?
3 days before, we had this discussion within the Greek myeloma study group physicians, and the majority suggested that they would go for such a patient, standard risk above the age between 75 and 80, for a quadruplet with lower doses of both bortezomib and lenalidomide, and of course, either very low or even no dexamethasone. So the vast majority of the doctors would go for a quadruplet, but with lower doses compared to what the IMROS or Cepheus have used. And I think this is what I would also do. For example, lenalidomide 10 milligram, and in a patient like that, 77 intermediate fit with 1 milligram per square meter of bortezomib.
Okay. Well, good point. That's true that when you're looking at the schedule of Cepheus, IMROS, and Benefit, the three studies looking at quad versus triplet, the schedule and the doses of each drug is not exactly the same, in fact. And in your practice, Paula, how are you using bortezomib? Are you still using twice weekly, or are you using once a week only? That was proposed in the benefit study, but not in IMROS and not in Cepheus, at least for the first cycles of treatment.
Yeah, so I probably the hard one here because I always have hard time reducing the doses. I must be honest, but in general, why I start Cepheus, I do first cycles bi-weekly. Not probably in this case 77 intermediate feet. So probably in this case I will go directly to weekly, but the case before 72 feet I would probably go first cycle bortezomib 2 times per week, so to achieve a fast reduction of the tumor burden, and then go to weekly. This is in general what I am doing now, and I agree with the point of dexamethasone that needs to be decreased very rapidly. Honestly, in this case, 77 for me, the dose of len is a question. So I probably would start with full dose of len 25 and then see how the patient tolerate. But I understand that maybe lower doses and then increasing based on the frailty. But yes, I generally do first cycle 2 times per week and then monthly. For older patients or frail, I will do directly weekly bortezomib.
Okay, so I understand that, well, from your opinions, experiences, you would like to use quad if possible in patients between 70 to 80 with dose adaptation according to comorbidities, reducing the dose of dex quite rapidly. We can also reduce the dose of len from 25 to 15, for example, if
Yeah.
needed, and the
Definitely.
weekly bortezomib as well. Okay, so let's move now to another case. And the patient is becoming now older, and is 83 years old with some cardiac comorbidity, a renal impairment, and the patient is frail. So 83, above the age of 80 years, frontline, obviously transplant ineligible. So what will be your choice? In fact, Roman, what are you going to do?
Again, it's driven by comorbidities. So cardiac comorbidity. Bortezomib is not, so good drug because we know about toxicity of proteasome inhibitors. So if I use bortezomib really significantly reduced dose, maybe once per 2 weeks, something like this. There is renal impairment, so we have scenario for reduction of lenalidomide in that setting. But what we are trying to do to replace lenalidomide with pomalidomide, which not required reduction of dose, and patients probably can benefit from this. So it's old, very frail patients. Maybe very thyroid triplet therapy or even doublet would be enough. But then again, we try to reduce dexamethasone dose. So for me, the regimen would be something between pomalidomide with reduced dose of bortezomib and limited dose of dose of prednisone, because in our Czech myeloma group guidelines, we are replacing dexamethasone with prednisone in patients above 80 years old.
Interesting, Roman. You are mentioning POM, but POM is off-label, frontline
Yeah,
treatment. That's that
we,
in
we,
my country it could not be possible, for example. So
we have to
Evangelos,
ask.
yeah,
We have to
okay.
ask the
Mm.
insurance company. That's for sure.
Okay, good. And Evangelos, are you using Dex sparing regimen as well? What do you think about the results of the study presented by Salomon Magnier, the French study looking at Len plus daratumumab, in fact, in frail patients? That's something that you would like to do?
I liked it a lot, and I congratulate the IFM for a lot of course, significant and important studies, but this is one of them in frail population. This is a frail patient by definition, uh, not only because of the age, but also has cardiac and renal comorbidities. So definitely a doublet, dexamethasone sparing combination would be probably enough for this patient. If there was no renal impairment, I would definitely go for DARA plus lenalidomide as the doublet. Now, with the renal impairment, of course, if this is because of the age or this is because of myeloma, this is also something that would be of interest to me. I could go, if it is for myeloma, with low dose of bortezomib with daratumumab, and then if we have the reversal of the renal impairment plus DEXA for the first cycle, only because of the renal impairment, and then if I have a reversal, I would continue with DARA plus LEN. This is also what we are doing more or less in the renal impaired patients with DARA plus
So that's
bortezomib as.
interesting, in fact, because in the guidelines, we are thinking about, okay, 70 quad autologous, that's fine. 70, 80 quad. Above 80, DRD or DRD adapted, Maya adapted without DEX as proposed by Roman and yourself as well. That could be fine. But now we are seeing that we could use, in fact, some proteasome inhibitors in order to manage the renal impairment. So that's not that simple, in fact, obviously, based on the comorbidities and the frailty of all patients. Paula, your best choice for this patient?
No, that was going to be my comment. So depending on whether the renal impairment was related to this disease, so to myeloma, I will go eventually for a first cycle with the DVD, so daratumumab, bortezomib, dexamethasone with weekly bortezomib, eventually starting at a lower dose. And then if then the renal insufficiency recover, then switch to the LEN. And if it's more related to hypertension, diabetes, or cardiac other comorbidities, then I will go probably for DRT, adapting the doses of LEN. And just as you discussed with following the IFM 2017 study with just 2 cycles of DEX and stopping the DEX very rapidly, since I believe this is one of the studies with the best PFS in true frail and poor performance status patient population. So yes, I would do that. But yeah, with the comment depending on the renal insufficiency.
Thank you, Paula. I believe that with these different cases, scenarios, we have covered quite a lot of topics and possibilities for our patients. But we are always speaking about CD38 antibodies, and frontline. And that's true that in some countries, we cannot have access to CD38 antibodies frontline. So, can you tell us, Roman, what about selecting therapy in areas in countries without access to all available agents? So, well, from the cost effectiveness point of view, maybe the VRD or adapted VRD could be a good option when we don't have access to all agents. Don't you think so?
Exactly, Philip, as you suggested. These two drugs are already generic, so the cost is significantly reduced. So whole regiment monthly cost, it's really limited. So I do believe that VRD is one of the quite good options in those country where the anti-CD38 and monoclonal antibodies are not available. We used VRD for many years, so we know it's working nicely. Definitely not so good as if we adding the anti-CD38, but for the patients, this is I think the cost efficacy benefit is really high.
Okay, thank you so much. So now, the same question for each of you. Looking ahead, do you anticipate, Paola, the treatment of newly diagnosed multiple myeloma will be the same in 5 years from now? If you have a crystal ball.
Maybe in 5 years it will be the same, but maybe in 6 we may already have CAR Ts substituting transplant for both, and for transplant eligible and also CAR Ts in the context of new transplant eligible patients. And there are also studies evaluating the role of bispecific antibodies in combination with the standard of care, or also as a consolidation strategy replacing transplant. So maybe in 5 years is very short time, it will be the same. Little more, it will be different.
Evangelos, what do you think?
It's a difficult question. CAR-T is to my opinion, the most probable entrance in the first line, especially if we have some data suggesting that with the CAR-T we can cure at least a fraction of patients. That I think that would be great without continuous maintenance. For the transplant ineligible patient, we have done a study with belantamab. I don't know if this can produce from the DREAMM-7 such good results in order to substitute daratumumab, but this may also give an option. I don't say that the patients would not receive an anti-CD38 upfront, but probably belantamab in some cohorts of patients give some solutions. For the bispecifics, although they are great drugs, I don't think that we know how to use them in the optimal way. I believe that the continuous use is totally not acceptable because of the side effects, especially those targeting the CMA. So this is what I'm seeing, that it may change after 5 or 6 years.
Thank you, Evangelos. Roman, what are your views?
Okay, I agree with Paula and Evangelos. There are two unmet need cohort in newly diagnosed setting, and Paula mentioned it, double hits or ultra high risk myeloma. Definitely, it's hard to treat and it will be difficult task, even for CAR-T and bispecific. The same story is for extramedullary disease. And then for me, we now discussing and trying to learn how to incorporate frailty adapted attenuate dosing strategy for quadruplets. After 5 years, we will effectively use this strategy. And to me, to decrease potential of toxicity without losing efficacy. And to me, is truly personalized treatment strategy in routine clinical practice for this heterogeneous group of our patients.
Thank you, Roman. Well, very, very good points indeed. And that's true that for transplant ineligible patients with quad, the bar is already very high. But on the opposite, that's true that we have CARTitude 5 looking at CAR-T frontline in transplant ineligible. That's true as well as mentioned by Evangelos. The goal of frontline for transplant eligible patients could be the cure, combining quad plus high dose plus potentially some immunotherapies subsequently. So a lot of possibilities and a lot of ongoing studies for sure. So with that, I would like to thank you, Roman, Paola, Evangelos, for this great discussion. And I would like also to thank our viewers today. Thank you for watching. And please proceed to the post-activity test and evaluation. Thank you so much.
This program was presented by Medscape Education Global.